Hi, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. My guest today, Dr. Rob Klein, is a successful podiatrist from South Carolina. Dr. Klein received his bachelor's degree in chemistry from Florida Atlantic University. He attended the William Scholl College of Podiatric Medicine. He completed his podiatric medicine and surgical training at Michigan Health Center. He is board certified by the American Board of Foot and Ankle Surgery and is a certified wound specialist. He also has a certificate from Cornell in strategic healthcare leadership. Dr. Klein is currently the medical director for the Vascular Health Alliance Wound Healing and Hyperbaric Oxygen Center in Greenville, South Carolina. He is the division chair for wound care throughout all of Prisma Health. He oversees 7 wound care centers. Welcome to Dean's Chat, Dr. Klein.
Thank you, Dr. Jensen. It's nice to be here, and thank you for the opportunity to spend some time with you today.
Oh, I look forward to it, Rob. It has been a while. Say, on Dean's Chat, we go with first names, kind of a fireside chat vibe. So you're Rob, and I'm Jeff for the rest of the discussion today.
Absolutely. How are you doing today, Jeff?
Oh, I'm doing great. I've really been looking forward to getting together. Just for the listeners, Rob and I have worked together over the years many times, and even doing podcasts like this, talking about total contact casting. So we'll touch a little bit on that as we go through the discussion today, Rob. But before, just kind of introduce yourself to our audience, can you tell us about your podiatric medicine journey? How'd you find out about podiatry?
Sure. I was doing my undergraduate work at Florida Atlantic University in Boca Raton, and I was interested in medicine. And some friends of mine had suggested you should shadow a podiatrist. So I reached out. I went to the phone book, actually, and I called a podiatrist. His name was Ken Richter. He had a very successful practice in Boca Raton. I think he has since retired, maybe became disabled. I'm not sure. But I shadowed him in his office for a whole summer. It was a phenomenal experience. I learned a whole bunch of things. It inspired me in so many different ways. And that was a career path that I really took. For me, there was really no other choice but podiatric medicine after shadowing him. I mean, you really touch people of all ages, young kids and grown toenails, warts, to wounds, to reconstructive surgery, to older patients. It was really a phenomenal practice and a great eye-opener for me on how to take care of people.
It's funny, Rob, so often we hear about that shadowing experience being when the light goes off and then a young undergraduate student says, I'm going to be a podiatrist, but it really takes that shadowing opportunity sometimes.
Absolutely. For me, it really was a life-changing event. I was looking at allopathic medical school, osteopathic medical school, and really podiatry was the best fit for me.
Very good. See, I was also going to share, I appreciated it last week, Rob, when we had the student visiting from South Carolina, and she is having some difficulty finding a shadowing opportunity, and I really appreciated you opening up your practice to let her come in and visit with you.
Absolutely. We've connected, and she's at Clemson, and I think she's going to come up to our upstate office. She's is kind of in between Columbia and Greenville, but we're going to come to Greenville and get a chance to shadow podiatry and wound care, because I'm primarily focused on wound care, but it'll give her good exposure to at least what you can do within podiatric medicine, the opportunities that you have, which are plentiful.
Oh, absolutely. We'll talk more about that. So after you did the shadowing down in South Florida, you ended up going up to Chicago to the Scholl College of Podiatric Medicine.
I did. I did the typical circuit. I interviewed at several schools. I think New York was my first interview. I'm from New Jersey originally. New York was so expensive to begin with to go to school there, and the tuition was high. The location, not picking on New York by any measures, but really was not where I felt was the good fit for me. Went to Ohio next, and Ohio was actually very exciting. They offered me some money as a scholarship. And then I went to Des Moines and then finished up interviewing in Chicago, and Chicago just was the right fit. It was a really cool city. The interview that I had in Chicago was just phenomenal. And I went home hoping that I was going to get a letter in the mail. This is in the days when we used to get things in the mail versus email, that I was accepted. And sure enough, I was accepted in Chicago, and that's where I wound up.
Well, that's fantastic. And then in your fourth year, you did clerkships and externships, I imagine. How did you end up at the Michigan Health Center?
That was a non-CRIP program.
Oh, okay.
So And this was during the days when there was a residency shortage, where some of the people in your classes weren't getting residencies. Some were going on to do preceptorships, some would do other stuff, and then get back into the residency game again. So I had interviewed at Rush and a couple other places. Rush was my first choice, actually. It was a CRIP program, and Michigan Health Center was not. And I interviewed with them, and they offered me a contract. And, a bird in the hand is worth two in the bush, right? That was when I had classmates that weren't getting programs. So I took Michigan Health Center and have absolutely no regrets whatsoever. Michigan, you trained in Michigan. That was kind of the place where podiatry really evolved surgically. And a lot of the people that trained you, were my mentors as well.
Right. I have some lasting impressions from residency in Michigan. Aside from the great training, we went 90 days in a row without seeing the sun.
The saying is, what happens with 2 days? What happens after 2 days of rain in Michigan? Monday. Because it seemed like every weekend that we were off, it would rain in Michigan. So we'd never have time. But I do remember it rained a lot. There was a lot of snow as well. I remember one day going to work. It took me about 3 hours. We lived in Southfield, and our program was maybe a mile from receiving. And it took me 3 hours to get into work, but I showed up just because of the snow.
Wow. Fantastic. So those are good times. And then, what I really want to do is spend some time talking about your current work situation. Oh, I also wanted to ask you, tell me about that certificate from Cornell on leadership.
I was looking at a career change because now I'm in a leadership role in my organization. Mm-hmm. And I actually had interviewed for a private company as well that was looking for a clinician. But they needed some type of either MBA or a graduate certificate. And I made it through the C-suite on the interview. Didn't ultimately get the job, but they said, you're a real strong candidate, but you need some leadership and business experience. I went and did the Strategic Healthcare Leadership Certificate Program at Cornell. Learned a whole bunch of things. Learned how to read a P&L sheet. Learned how to navigate, painful relationships, learned a lot about the business side of healthcare.
Well, it must serve you well because you are overseeing 7 wound care centers right now.
I have 7 wound care centers that I oversee. A little bit about Prisma Health. We're the largest not-for-profit healthcare system in South Carolina. We have a footprint in the upstate and the Midlands of South Carolina. We have 18 acute and specialty hospitals in 21 counties. Wow. So it's a large healthcare system. We don't have a big podiatry footprint. We only have 4 podiatrists within the whole system, 2 within wound care and 2 within the ortho service. So from a podiatric perspective, there's a lot of opportunity, I think, within Prisma Health if we can align all of the departments to bring more in. But that's a little bit about Prisma Health. And for me, I practice wound care full time. I do wound care and surgery, and then I have my administrative role as division chair.
So let me ask you kind of a loaded question. What did you learn in your Cornell Leadership Certificate program that's really helped you out in overseeing other podiatrists and other wound care centers?
Navigating power relationships, that's really hard. There are a lot of different personalities within medicine. Some people have some strong personalities. Other people are a little bit more laid back. Learning how to, I guess, play nice in the sandbox. I work with vascular surgery. I have to deal with orthopedics, general surgery, infectious disease. I'm one of 13 divisions within the Department of Surgery. Orthopedics has their own department. I'm actually in the Department of Surgery. And then the other 2 podiatrists within the system are actually in the orthopedic department. So I work with the other surgical divisions: neurosurgery, vascular surgery, general surgery, urology, plastics. So it's interesting, working in that sandbox and playing nicely with all the different specialties.
Yeah, I got to meet everybody's needs.
Absolutely. Yeah.
So let's talk about the wound care centers a little bit. In the one, do you work in 2 of the wound care centers?
I work in 2. I do some coverage at the other centers. The main center that I work at is what I would consider our flagship center. It's an academic type of center. It's an interdisciplinary center as well. We have podiatry, a nephrologist, internal medicine, general surgery, infectious disease. We have APPs. Vascular surgery is part of this center. It's called the Vascular Health Alliance. So vascular surgery is on the same floor as us. We have prosthetics and orthotics right down the hall. So when we need offloading, we just send them right down the hall. It's a very much a teaching wound care center. We have MS4 medical students that rotate. There's a 2-week wound care rotation for the MS4 University of South Carolina School of Medicine, Greenville. Students that rotate. I have family practice residents that have a 2-week rotation with me. Vascular surgery rotates with me every Monday, and infectious disease rotates with me on Thursdays. So it's a big teaching environment. Unfortunately, I don't have podiatry yet. I reached out to one of the podiatry schools, hoping that I could get some interest to have a student come down, but since we don't have a residency associated with our institution, it's really hard to attract people to want to come to South Carolina, knowing that there's really not a program for them just yet. I'm working on developing a wound care fellowship, which I hope would entice people to come.
Sure. When I was in Miami, Dr. Snyder had a wound care fellowship. And that helped a lot because we had all those clinical trials, and what an opportunity for a young, successful doctor with lots of aspirations to get into wound care.
So I've submitted the paperwork at our institution for approval. It would be a non-ACGME type program. We have a huge need for head-to-toe providers within our system because we have 7 centers. We do hyperbarics as well. And in South Carolina, podiatry cannot oversee hyperbarics. So I've got to train head-to-toe providers, but within my plan is to have 2 fellowship spots, one for podiatry and one for allopathic or osteopathic provider to come learn wound care as well. Wow. And then for us to train and retain those providers.
For sure.
Because we have an older wound care service or section. So I have a lot of, I should say a lot, but I have some providers that are getting close to retirement age that I'm going to have to replace the head-to-toe providers.
Right. I have a question for you. I used to also train family medicine residents when I was in practice in Denver, Colorado. What have you found the biggest challenge, or what are those eye-opening experiences that, family practice residents have when they follow you around and they see you treating all these diabetic foot ulcers, venous leg ulcers, and on and on?
A couple of different things. First off, they're surprised at the scope of what a podiatrist can do. In South Carolina, a lot of these family practitioners have never really interacted with podiatry before. So giving them, some perspective of what we can do and how we work very symbiotically together. The other eye opener for me is they're shocked when we talk about A1Cs because, they're managing the A1Cs a lot. And a lot of the patients that we see are poorly controlled diabetes that have A1Cs of 12, 14, a lot of double digits. And they realize that they need to get better control of their patients' diabetes. That's an eye opener for them a lot of times.
I can imagine. So education's in your blood. I know that for sure, because you and I have done a bunch of programs together around the country. Let's spend a couple minutes talking about your consulting and some of the research that's kind of resulted from that. You currently consult for several companies. And how'd you get into that, Rob? It
was really interesting how I got into it. I was doing a preceptorship, and this is kind of an interesting. You really kind of teed it up very nicely. Thank you, by the way. So I went out and did a preceptorship at Georgetown. 3M had sponsored, a few days at Georgetown with Steinberg, Paul Kim, and the plastic surgeon. I'm pulling a blank on his name. Chris Attinger. So we got a chance to shadow them in the wound care center, go down to surgery, watch how Attinger did his baloney amputations, which is a little bit different than elsewhere. Paul and John would give us lectures on wound care. And I was going out to dinner with one of the reps that, had helped me get that preceptorship to go out there. And she said, let me see some of your wound care cases. And I showed her some of my cases. And she said, this would make for a great poster. So I did a poster with 3M. And then I did several more posters with 3M, and eventually it turned into a manuscript. And then it turned into speaking. And now I do a lot of work with them as a result of simply doing a preceptorship. And to where it comes full circle is, I did the preceptorship with Paul Kim many, many years ago. Really when I was just cutting my teeth in podiatry and wound care. And then I had the honor to be on the podium with them at the last SAWC, where we were talking about instillation and draw therapy. It was me, Paul Kim, and Dr. Dardano, a plastic surgeon out of Boca Raton. So the circle went really complete. Guy who trained me in wound care, now I'm presenting on the podium with him.
Wow. So what kind of products are you working with 3M right now? Or that have you worked with them?
I do a lot with negative pressure, collagen silver, Promogram Prisma, Factor Flow, pretty much their whole portfolio for the most part. But it's stuff that I was using all along. It wasn't they came to me and said, Rob, here's a contract. I want you to use the products. Everything that evolved with my relationship with 3M was because I was using their stuff and their products and their portfolio and getting really good outcomes. And that's how it kind of just fostered over the years.
That makes sense. A lot of lessons there, right? I tell my students and residents all the time, if you want to get on a path towards speaking, get some good outcomes with patients, exactly what you did, show what the products can do. Next thing you know, you do a poster and it leads to a manuscript, and exactly, that's a good playbook you have there.
Yes, it works for me. And for the students that come and shadow me or ask my advice, I think that's the way to go.
Yeah, me too. Hey, I got a funny story to tell you about 3M. About 20 years ago, I was trying to sell the total contact cast company I had, and 3M was one of the companies that was interested. So when I went to do the pitch, right, flew to Minneapolis and tell them what we're about. My first slide said, "You're 3M, we're 1M, we're Metaphysiency," and it didn't work out. But I'll tell you what, 3M is a quality company, really, really good company.
I mean, they're a great company. The portfolio speaks for itself. When I do some talks, I list what are the greatest impacts on my wound outcomes. And, for me, endovascular revascularization for sure is a huge impact on my outcomes. The second one is really negative pressure wound therapy. I can't close the wounds the way I do without negative pressure wound therapy. And then the third one really is our advanced wound care dressings. And for me, the portfolio that 3M has is just a very robust portfolio for me with advanced wound care dressings. And then the fourth thing I say is my greatest impact was the nurses that I worked with throughout my career, because a lot of the wound care that I learned, especially product that we use, I learned through the nursing staff. So that's one of my slides in my slide deck, is the greatest impacts that I've had on my wound outcomes. And those really are the four things.
No, that's great. Let's talk for a minute about Integra's Total Contact Cast, the TCC-EZ. You and I have lectured together and done programs together on that. And I love your story about utilizing skin equivalents and how you transitioned into casting. If you wouldn't mind sharing that story, I always enjoy listening to it.
Absolutely. When I came to South Carolina, they didn't have podiatry at the center at that particular time. So there were a lot of diabetic foot ulcerations that were just kind of hanging out. They were just chronic wounds that either needed more aggressive debridement, more aggressive offloading, maybe surgical offloading, things that I had in my toolkit that the other provider at the center at that time did not have. So I was using a lot of skin subs on a lot of these chronic wounds my first year. We were ordering a lot of skin subs. I think our rep was maybe the number 2 rep within the country for this one particular company. And then, I had this epiphany about total contact casting, and I started total contact casting. And then at that time, I was also transitioning over to division chair for our system. So being a good steward of the system, looking at cost of the system, cost to not only our system, but the healthcare system nationally. And I found that I could close wounds so much more quickly with TCC Easy that light switch went on, and my utilization on skin substitutes went down significantly, and my utilization of total contact casting went up. And wounds that I would close with CTPs, maybe over a 2 to 3 month period, I would close in 14 to 32 days, 36 days with a total contact cast, with huge significant savings to the system. So being a good steward of the system, doing what's right for your patient more than anything else. The longer the wounds open, more likely they're going to get infected or have a problem, maybe have an amputation. So doing the right thing. And, for me, that was a journey, but a very good journey for me. And I think for my patients as well.
Oh, that's great. I've always enjoyed you lecturing together on the podium and doing workshops and things. And I always enjoy listening to your talks. And I know that the words of wisdom that you're talking about, and literally the people in these workshops go home and they start employing casts on their patients. So you do a great job in that regard.
What's interesting with total contact casting too, I do a lot of high risk patients. So some of the people that I cast, they might have a below knee amputation on one side with the prosthesis. And some clinicians wouldn't even think about casting the other side. And for me, that's not a huge factor for me, as long as they can still get around, maybe with a walker or some type of assistive device. But I cast people who've had partial amputations of their foot, people who have a contralateral limb amputation. For me, the only contraindications are the ones that are on the IFU.
Right. Well, that's great. So there's lots of opportunity in the wound care space, and there's always new products coming out. Have you seen anything that looks like a game changer on the horizon for the wound care community?
Gosh, there's just so much going on. And, with the changes that are going on with some of the Medicare Max with CTPs, right. Some of the things that are promising, I don't know if they're even going to be coverage for it with the new LCDs that are coming out for cellular tissue products. I think some of the synthetic extracellular matrices that are available, bioactive glass, are interesting. Topical oxygen certainly is very interesting. So I think those are two things that I see very interesting on the horizon, or that are being utilized, that have a space within wound care.
Yeah, I agree with you. In your practice, what role does hyperbaric oxygen play, and which patients are you finding that they really benefit from it?
We obviously we're at a hyperbaric oxygen center. That's not my driving force. What motivates me to put people into the chamber, but the typical indications: Wagner 3, diabetic foot ulcerations, chronic refractory osteomyelitis. We dive other things too, like radiation cystitis, osteoradial necrosis. So we dive people with head to toe indications, but from a podiatric perspective, Wagner 3s and chronic osteomyelitis are the ones that we dive, traditionally.
And what cellular tissue products do you use in conjunction with hyperbarics? Do you cast? I mean, is it just another adjunctive therapy to add to the overall benefit to the patient?
I do cellular tissue products. I use a wide variety. I like dermal products a lot. They just work good in my hands. So TheraSkin is a product that just for whatever reason really works well in my hands. I think more than anything else, I worked with a plastic surgeon when I was learning wound care in Texas. I had practiced in Texas before coming over to South Carolina. And he felt that wound bed preparation was the key critical component to really getting a wound to be able to take it on to closure. And he had a saying he could close a wound with cat spit if he did proper wound bed preparation. And I don't know if you can close a wound with cat spit, but I do believe if you do good wound bed preparation, do good wound offloading, the cellular tissue product is just really adjuvant therapy in combination with the wound bed preparation. So I don't really have a cellular tissue product that really outperforms the other, but in my hands, for sure, TheraSkin is one that I do like a lot. That seems to work really well for me.
You reminded me of a lecture by Gary Gibbons from New England Deaconess back in the day. He was saying that, you have to debride the wounds appropriately. You need to prepare that wound, convert it to an acute wound so it can go through the stages of wound healing. And there's a lot of support for that. Get that inflammatory phase out of the way, get them into the proliferative phase of wound healing, and amazing things happen.
Yeah, there was a great consensus document that was published in, I think, General Wound Care in 2019. Greg Schultz and his team, they met in the UK, and they expanded the time principle to the timers, where they added regenerative properties and factoring social issues for the patient. But the time principle, Greg Schultz published the first article, Wound Bed Preparation, A Brief History in Time, in 2004. He did a second article in 2012, extended the time principle, and then in 2019, they did the consensus document. And really, when I have learners on my service, I teach them about time or timers all the time. That's one of the foundations for me when we talk about wound care is good wound bed preparation.
Yep. Could you expand on the time? Expand on that. That'd be great for the audience.
Yeah, time. It's an acronym. Tissue. You got to take all the devitalized bed tissue off. If you don't, the wound's not going to heal. The I component is infection and inflammation. So a lot of these wounds you were talking about are chronically inflamed. There's a lot of matrix metalloproteases and reactive oxygen species within the wound. So you got to convert that wound to a more hospitable environment by taking care of the inflammation. Obviously, address any underlying infection with antibiotics. M is for moisture imbalance. So you got to handle exudate either through an advanced wound care dressing or negative pressure wound therapy. E is that non-advancing wound edge. So if you have rolled edges or epibole, tunneling, undermine, you got to freshen and refashion that wound edge. The R is regenerative properties, extracellular matrices, your collagens, skin substitutes, negative pressure again. And then S is the social, making sure that you're addressing the social needs for the patient, adherence to the wound care program, smoking cessation, things like that. So that's basically the time or the timers concept or principle to wound healing.
I think every practitioner, healthcare provider, doesn't matter what their specialty, if they were introduced into wound care utilizing that acronym in new vascular status, and I think it would make a big difference in the outcomes we see out there.
You're very much right on that. And I use two acronyms all the time in my practice with my patients. I tell them, first off, we talk about the VIPs because the VIPs are very, very important, vascular status, infection, inflammation, and pressure relief. I usually will say, I have VIPs in my life, they're my kids, but the VIPs for wound healing are, you got to have good blood flow, you got to take care of infection, you got to get pressure off of your foot. So that's where total contact casting really comes into play. And the other one I talk about is the time principle, because a lot of times I do have a learner kind of anchored to my elbow. I'm either a student or a resident. And so I talk about time, but also teach the patient about it, because you can do it in layman's terms. Say, the reason I'm debriding your wounds, I got to take the bad tissue off. I got to convert it to an acute wound versus a chronic wound. I got to address the inflammation. I got to take care of the moisture balance, and I got to get an advancing wound edge. So you can teach the patient at the same time, but also teach the learner as well.
Oh, that's fabulous. I think the art of teaching is to simplify things so you get the essentials across in a reasonable way that people can remember them, and you've got that down, Rob. I've seen you lecture so many times. I commend you on your ability to communicate with patients and healthcare professionals alike.
You're way too kind, but thank you.
So, Rob, I wanted to pivot a little bit and talk about your professional service. You're currently on the board of the American Board of Wound Management. Can you talk about how you got involved in that board,
yeah, absolutely.
and then what you're doing currently to advance wound care?
So ABWM launched, I became board certified with ABWM, because you become a certified wound specialist with them. So I did the wound prep course with Dot Weir, Lee Ritzy, Pam Scarborough, and Dr. Patterson from Mississippi. That was the thing that put a fire under me. Going to that prep course, I knew I wanted to come back to my community and be a better wound care provider. So I sat for the boards, and then, just through communications with ABWM, they had an ambassador program to expand, the benefits of having certification within wound care. So I became an ambassador for ABWM, and there is a podiatrist that's on the board of directors, and there was a position that opened up, and there was someone recommended me. And so I submitted my, statement why I wanted to be on the board. And then I became a member on the board of directors for ABWM. Shortly thereafter, I became secretary. So I served as secretary for a year or so. And then by fortune or misfortune, I don't know just yet, I'm president-elect for ABWM for the next cycle when Dr. Barris rotates off.
The real work will probably start once you're the president. It's like the vice president and the president. We'll see.
He was out for a brief illness, and so I wouldn't say I assumed the helm, but I was doing a lot of calls that typically Ali would do. So I got an eye of what you do as an elected or a nominated person, and there's a lot of work for sure.
A little glimpse of the future there.
Yeah.
What are top priorities for ABWM?
For sure, getting the word out, the importance of becoming board certified, seeing a board certified wound care provider as well. I think is one of our big missions. We certainly want to certify more people. We want to educate the public as well about the benefits of seeing a board certified wound care provider versus seeing someone who's not board certified. Because obviously there are some standards that you have to go through to meet board certification. So that's pretty much one of our biggest functions for ABWM.
Fantastic. Now, something that's near and dear to your heart, you and your family has been very involved in the United States Naval Academy, and you're a blue and gold officer. Can you explain what that is and why you're there? I think it's just a great story.
So my son was applying to the Naval Academy, and part of the interview process to get an appointment and commission to the Naval Academy is you interview with a blue and gold officer. Could be someone who was former military, current military, or it could be a civilian like myself. I actually have no military service at all. So we lived in rural Northeast Texas at the time, and we had to drive 3 hours close to Dallas to where the nearest blue and gold officer was. Fortunately, my son wound up getting an appointment commission to an appointment and nomination to the Naval Academy and attended it. And I became friends with the area coordinator who handled all of the blue and gold officers. And I said, my son and 6 other kids from our area traveled 3 hours. Is there any way that I can help you out? And he said, don't ask for something that you don't want to do. So the next thing I know, I'm up in Annapolis at the Naval Academy doing my blue and gold officer training. And I became a blue and gold officer and mentored a whole bunch of students, some that got into the academy, a lot that didn't. In Texas, and now I do the same thing in South Carolina. And it's very rewarding when you meet these kids. You see some incredibly promising kids that face tremendous adversity. I had a young lady in Texas whose mother was incarcerated. Her mother had HIV. She was homeless. She was going from house to house living on a sofa, and she applied to the Naval Academy. Very worthy candidate. I've met some very, very interesting kids that have done just some amazing things over the past, been doing it since 14, so 9 years.
And your son graduated this past year.
Oh, no, my son graduated in 2018, and then by pure serendipity, my daughter went to the Naval Academy as well. So my daughter, my son's class of 2020, my son's class of 2018, and my daughter is class of 2023. Oh, okay. And my son's a submarine officer. My daughter is in nuke power school right now with the intent to be a submarine officer when she finishes nuke power school. Wow.
Congratulations.
Thank you.
It's so great. You give back in so many ways, both professionally and thank you for your service in that regard. That is just wonderful.
It's for me, it's very gratifying. Mentorship, I think, is really important. We talked about shadowing, but mentorship is equally as important as well. And if you can mentor a student on a career path or maybe to a college, it's very fulfilling. There's no quid pro quo. You're doing it purely out of the goodness of your heart because you want to help people. It's a really neat experience. So for people that have not done mentoring, I highly encourage it because you get so much more out of what you give in helping these people.
Oh, that's great. So when you have opportunity to have a podiatry student come and visit, what do you tell them about the profession? What would you say to a student that wants to come to the Arizona College and they rotate with you? What do you tell them about podiatric medicine?
Yeah, I tell them that, there are so many opportunities within podiatry. And I use my life experience as that. I did my podiatry school in Chicago, as you shared. I did my residency in Detroit. Actually worked with a headhunter. I got my first job through a headhunter. We had a recruiter at our hospital. We had all the residencies at our hospital. So there was a recruiter that just had a posting up. So I shared my CV with the headhunter. Wow. That's how I got my first job. So I got my first job. It was in both Arkansas and Texas. So I was sponsored by a hospital to come down and serve their community, and then eventually became my practice. I then had several offices in Texas and Arkansas, and then was invited to join a multi-specialty group in Texas. So then I worked as a physician partner or owner within this multi-specialty group. And then my interest in wound care became much more prevalent. I found that was much more satisfying to me than doing a bunionectomy or an ingrown toenail. I got much more out of it, and I felt like I was giving a lot more to my patients. And I wanted to do more within wound care, and I was on the speaking circuit at that point. and I was in Charlotte presenting, and I met someone from Prisma Health, and they said, we need someone with your skill set. Would you be interested in coming to Greenville? And that's really how my evolution to wound care happened. But I've done all aspects of podiatric medicine. So I tell the students that rotate with me is, you can be a general podiatrist. You can take care of, simple things, warts, ingrown toenails, diabetic foot care. You can be a surgeon. You can focus on biomechanics. You can focus on wound care. Really, the world is your oyster within podiatry. There really are no limitations with your DPM degree. You can really be on par with a lot of your other medical professionals. I mean, my colleagues in my system treat me no differently with my initials after my name than with an MD or a DO. So I tell the students that as well. It's a great profession, great lifestyle. You have a good income, good quality of life. You can do very interesting things, and you can really help a lot of people, especially in the wound care side, which I find very gratifying.
Absolutely, and well said. One other thing I wanted to ask you about, you've been very active. You've actually done some triathlons and marathons in the past?
I have. I've done many marathons. I did New York City Marathon twice. I did in 2006, 2010. Did the Houston Marathon, White Rock. I've done a lot of marathons, and then I got tired of running. So I bought a bicycle, and I started cycling with the triathlon club. And then, of course, one thing leads to the other. So I did my first triathlon with my tri club. And then, a sprint triathlon evolved to an Olympic distance triathlon, which evolved to a half Ironman. And then I went up doing two full Ironman triathlons, Ironman Texas and Ironman Chattanooga.
Oh, that's fantastic.
So I have done some triathlons in my days.
Very good. And I ask you that question kind of as a lead-in because a lot of students ask me about work-life balance. If I go into podiatric medicine, what's my life going to look like? And you're a classic example that you're not married to the job. You can be, but you've done a lot outside of podiatric medicine. So you're a classic example of a good work-life balance.
I think wherever specialty you choose, having that work-life balance is really important. Exercise is important. Spending time with your family is important. There are some people that wind up being married to their job for maybe because they don't have other outside interests or hobbies. I love my job. I love what I do, but I love spending time with my family. I like exercising. I like being outside. So you just got to find what really, motivates you or drives you outside of work. I have some friends that unfortunately who are in medicine that's all they know. They're 72, 74, 75 years old that are still practicing because they don't have any other outside interests. I don't see myself that way. I don't think I'll be practicing wound care or podiatric medicine at 74. Hopefully I'll be doing some of the things that I enjoy doing outside of work.
Well, fantastic. I'm sure you will be, Rob. Well, we're running a little short of time. I wanted to thank you for taking time out of your busy schedule and talking with me on Dean's Chat and sharing your podiatric journey. And for everybody that's on the show, Rob, I send them a Dean's Chat cup. That way you can get caffeinated, before one of your bike rides or something.
Absolutely. I would be honored to have one. I'll raise a glass to you when I get it. And I thank you for the opportunity to have me on your show. And for people that are interested in wound care, they're more than welcome to reach out to me, and I can share, my journey in wound care and, opportunities as well.
Well, I can guarantee you we're going to be knocking on your door when students in the South Carolina area are looking to have a mentorship shadowing opportunity, and we appreciate your willingness to do that.
Absolutely. Thank you so much, Jeff.
You're welcome. And to all of our listeners out there, if you're listening on Spotify or Apple Podcast or Google Podcast, please give us a 5-star rating. And if you're watching on YouTube, by all means, please become a subscriber. So until next week, cheers, everybody.